Hello, welcome to dental board exams, national board review. So we're going to review the famous and the most complex joint in the body, which is the temporomandibular joint. Okay, so we're going to look at its anatomy, and then there's a second part to this where we're going to look at the temporomandibular joint and its surrounding structures. Okay, all right. So what are the anatomic determinants of occlusion? So we have reviewed in the previous lecture, before this one, we reviewed the anatomic determinants of occlusion, and you know there are four anatomical determinants of occlusion. Okay, and this is the right TMJ, the left TMJ, the permanent dentition. Okay, now notice that I mentioned permanent, not primary. So primary teeth, they have to maintain the arch space, but they are not critical. They are not determinants of the final occlusion. Okay, now, and the fourth one is the neuromuscular system, where you have the masseters, the pterygoids, okay, and the temporalis muscles. Also, you have the infrahyoid muscles, which play a role. Okay, so there are four determinants of occlusion. Okay, all right. So the temporomandibular joint is classified. All right, the temporomandibular joint is classified as a compound joint, and this is because the articular disc functions as a third bond between the condyle and the temporal fossa. Okay, so it's a compound joint. All right, so you have three components. You have the condyle, you have the temporal fossa, and you have the disc. All right, okay, so the TMJ has been described as a ball and socket. Okay, as you can see here in the picture, you can see the condyle, all right, which is here, and you can see the fossa. Okay, now it looks like the condyle is a ball and then the fossa is a socket. Okay, but this is not accurate, and the joint functions more like a ball on a ramp, because remember, just unlike any other joint in the body, the TMJ has the articular eminence, which is right here. Okay, and so the condyle and the disc have to translate on that posterior surface of the articular eminence. So it's more of a ball on a ramp. Okay, the articular surface of the condyle functions against the posterior slope of the articular eminence. Make sure I keep that in mind. Okay, it's the posterior slope, which is right here. Okay, so this is anterior part of the slope of the anterior of the articular eminence, and this is what is line here. This is the posterior slope. All right, and the condyle is functioning on the posterior slope. Okay, so you have to keep that in mind. Make sure you understand what you are looking at. Okay. Any questions so far? So let's move on. Okay, so here you can see that the TMJ, the condyle of the TMJ, okay, is part of the mandible, and the mandible articulates with the cranium. Okay, because so when I say what bone does the mandible articulate with, so you have to know that the condyle is part of the mandible and it articulates with the cranium. Okay, so the temporal bone, of course, is part of the cranium. So you have to know that sometimes if you have injury, because the part of the temporal fossa is very thin, sometimes when you have injury, the condyle can go in the cranium. And now, which part of the cranial fossa will it go to? Is the middle cranial fossa. Okay? So, each joint connects the mandibular condyle with the glenoid fossa and the articular eminence of temporal bone. Okay? So, which bone do you find the articular eminence? Is the temporal bone. Okay? Temporal bone is the one which makes up the articular eminence. The articular disc is positioned or interposed between the condyle and the glenoid fossa. Okay? So you can appreciate on this image here, you have the condyle, this is the condyle, and you have this articular disc right here. So articular disc, the way you identify it, looks like a bow tie, okay? Or sometimes the shape of a bone, okay? And from there you have the eminence, okay? So you can appreciate the eminence, which is right here, all right? And you have some muscles here, okay? So you can appreciate the muscles here, all right? And this is the retrodiscal tissue, okay? So you have to know all that anatomy, and you have the external acoustic meatus, okay? Or external auditory meatus. Auditory, okay. All right. All right, so I don't have my eraser here, but of course, yeah, you can auditory if you don't. All right, that's the correct spelling of auditory. All right. Now, let's move on. So now, as I mentioned, the glenoid fossa forms the roof. Okay. Now, and the glenoid fossa, where is it? This is the glenoid fossa. So you can see here on the diagram, it's pointing right there. Okay. That's the glenoid fossa. Now, as I mentioned before, the glenoid fossa is very thin. Okay. Which is a reason if you have trauma, you can injure, you can fracture that glenoid fossa, and then you have intracranial bleed. And so essentially the glenoid fossa is not a stress bearing area. Okay, because it is very thin, it cannot support the pressure that is applied by the condyle. So if you remove the disc, there's a high chance that that bone is going to be, the glenoid fossa bone is going to be fractured or resorbed because it is not a stress bearing area. So how does the TMJ, okay, maintain, okay, the stress? How does it control the stress applied? Meaning the forces that are applied to the TMJ. How is it controlled? And this is because you have the articular disc in between. Okay, and we're going to look at that. The temporomandibular joint, okay, it is part of a bilateral joint system. So remember, this joint is complex in the body because it is the only joint in the body whereby if you affect one side, the other side is also going to be affected. Okay, so they both work in unison. The left and right TMJs, they work together. Okay, and the mandible is interposed between the two joints, and any movement of the mandible will affect both joints. Okay, all right. As you can see, so remember from the previous lecture, so you have to review the previous lecture. From the previous lecture, when the one side is rotating, when you have a rotating condyle, the other side is orbiting. Okay, so they work in unison. All right, so you have to keep that in mind. Okay, so the articular surface of the condyle and the glenoid fossa, they are covered with dense fibrous connective tissue. Okay, so what covers the articular eminence of the TMJ is dense fibrous connective tissue, and it is not hyaline cartilage, which is found in other joint. So in other joint, the knee, okay, as an example, you find hyaline cartilage. However, in the joint, in the TMJ, what you find covering the articular surface is the dense fibrous connective tissue. All right. I hope that's clear. The layer of the fibrous tissue is thin in the fossa. Remember, because the disc is formed like a biconcave, okay, and the bone on the articular the glenoid fossa is very thin. Also, the fibrous tissue covering the glenoid fossa is also very thin, but it is very thick on the articular eminence. All right. This is the reason in CR. So we're going to go. Everything comes together when, because the glenoid fossa itself is very thin, and the dense fibrous connective tissue over the glenoid fossa is very thin. Okay, so you can look at the picture here if you want. This is the picture. Okay, this is the picture here. So the glenoid fossa, the dense fibrous connective tissue is very thin. However, it is very thick around the eminence, which is the reason when you are in C. So now the question is, how come the glenoid fossa bone doesn't get resolved frequently? Because our condyles, when we are resting, most of the time it's in CR. Okay, and the CR position is the most superior and anterior portion on the posterior surface of the articular eminence. So you're actually the condyle actually rests. You see the way the condyle is resting. So the condyle is not resting. It's not resting here. It is resting here. You see that? So it's not actually in between. It's not in the joint exactly. So this position actually is called CR, and that's because that's the thickest part of the dense fibrous connective tissue, and so it is less likely to resolve. Okay, so everything is nicely designed here, and everything goes together. Okay, anatomy and function. Okay, they all go together. The fibrous tissue is situated to the demands. Okay, it is so you see that the dense fibrous tissue, okay, the dense fibrous tissue is suited to the demands of movement and more regenerative capacity than cartilage. Okay, so the fibrous tissue has some regenerative capacity when you compare it to cartilage. All right, so in a joint which is always moving, when moving, it's either moving when you're eating, moving when you're talking, okay, yawning or whatever you're doing, but that joint is always functioning. So to prevent it from wear, there's always the fibrous tissue has a regenerative capacity. All right, but however, when you compare to cartilage, cartilage doesn't regrow easily. If you want to regenerate the cartilage, it's very difficult. So the TMJ is also unique when compared to other joints of the body because the movement of the joint is affected by an outside structure, which is teeth. Okay, as we mentioned in the last lecture, we saw that the the stiffness of the articular eminence. If it's too steep, the cusp tips of the teeth are going to be long. Okay, if the cusp tips of the teeth are long, the prominence of the articular eminence of the TMJ has to be also steep. All right, and if the articular eminence slope is very shallow, okay, then you're going to have flat cusps of teeth. Okay, so occlusion does affect TMJ. That's why malocclusion can cause internal TMJ derangement. So the adult condyle is approximately 15 to 20 millimeters long, okay? And mediolaterally, so this direction here, mediolateral, is 15 to 20 millimeters. And anteroposteriorly, okay, anteroposteriorly, it is 8 to 10 meters wide. So it is the TMJ is like a what do I say? It's like a football, not soccer ball. The soccer ball is round, but football, American football. Okay, so it's like that. It's like an egg, almost. All right. So the medial pole. So you have the medial pole. This is lateral. This is medial, and you would say, okay, how? So this is, I'll say medial. So you would say, how do you know this is lateral, this is medial? Okay, so you can see, if you know the anatomy of TMJ, you can see that this is the lingular, right? This is the lingular. This is where the sphenomandibular ligament attaches. All right, and so this is on the medial side. All right, that's how you identify. So you have to know your anatomy. So the medial pole is more prominent, meaning it's pointed. As you can see, this is the lateral pole. The medial pole is almost like pointed like that, okay, compared to the lateral pole. And when viewed from the side, the condyle is quite convex. So make sure you remember that, okay? The condyle is quite convex when you're viewing it from the side, okay? Anteroposteriorly. Anteroposteriorly, so anteroposterior, the condyle, you have a convex condyle, okay? Make sure you remember that, okay? All right. And when you're viewing from the front, the condyle is slightly convex. So all in all, when you look in all directions, the condyle is convex. So it's like a football, okay? Everything is nicely rounded, all right? Convex surfaces, okay? Anterior, posterior, mediolaterally, the condyle is convex. Now, what's the opposite of convex? If you put two objects which are convex together, if you, for example, you put two footballs together like this, there's no stability here, okay? It's not going to be stable. You can't move. So you need something opposite to convex. What's opposite to convex? Is concave. So if the condyle is convex, the glenoid fossa has to be concave. Now, to make it interesting, also when you put the condyle, okay, the normal anatomy of the condyle and the glenoid fossa without the disc, it is incongruent, okay? It is incongruent. So there's no congruency. They are not equal in shape. They don't fit properly. All right. That's why it's not a ball and socket. All right. Because the condyle, without the disc, the condyle itself does not fit in the glenoid fossa. Make sure you remember that. When you take out the disc, the condyle does not fit, okay, in the glenoid fossa. And usually the pictures that are shown on the skeleton or some of the skeletal models, it shows that, oh, the condyle is fitting in the glenoid fossa. That's not true. The glenoid fossa is kind of ragged, okay? And so when you look at the disc is a three-dimensional. It is not actually, it is not, it helps to distribute the forces along the glenoid fossa, because the glenoid fossa, it does not fit to the condyle, all right? So the articular disc has to be biconcave, all right? So articular disc is biconcave disc. The condyle is convex. The articular disc is the condyle is convex and the articular disc is concave. All right. So if it, I had a student who asked me, what is convex, what is concave, right? So it depends on where you're looking, but it's essentially, if you're looking from outside, for example, you're looking from here, okay? If you are here and you're looking up, so something which is concave is going to be like this. Okay, and something which is concave, I mean, this is concave. This is concave. Convex is going to be something opposite. It's going to be like something like this. Okay. So this area is convex. All right. So you have to understand that. Okay. So the articular surface of the condyle is on the superior anterior border of the condylar head. That is where the anterior superior, so this one, AS, that's anterior superior. Anterior superior is where the articular surface of the condyle is. This is correlates to the position of centric relation. Centric relation is when the condyle is in the most superior anterior on the posterior surface of the articular eminence. I'll keep saying that so that you know the definition of CR. The articular surfaces, okay? The articular surface face forward and upward to approximate the posterior slope of the articular eminence. Okay? All right. So let's see. All right. So let's look at the glenoid fossa. All right. So the glenoid fossa is also called the mandibular fossa. It's bordered by the articular disc and the anterior surface. Okay. So, I mean articular eminence. So AE here is called articular eminence. So this is the posterior slope of articular eminence, and this is here is the anterior, and the glenoid fossa is right here. The F stands for fossa. Okay, AE, articular eminence, and the F is the fossa. Okay, And the GT is stands for glenoid tubercle. Okay, glenoid tubercle, which is on the posterior surface, right in front of the ear canal. Okay, that's the ear canal. All right. So the glenoid fossa or the mandibular fossa is bounded anteriorly by the articular eminence, and the posterior glenoid process, process and the posterior articular lip, they border the glenoid fossa posteriorly. Okay, so the glenoid process or glenoid tubercle, they are on the posterior, and in the anterior you have the articular eminence. Okay, all right. So here, when you have an arrow, or there is a narrow or low ridge which may form the lateral border of the fossa, and the fossa narrows medially. Okay, remember the medial paw is pointed. Okay, the medial paw of the condyle is pointed, so the fossa narrows medially. Okay, and is bounded by a bony plate that approximates the spine or sphenoid. Okay. Now, the articular disc, as I mentioned before, this articular disc is a biconcave. So it has two concave, all right? So the articular disc is like that. Okay. Like this. All right. So what we have here is the biconcave structure, which is the articular disc, and the thinner, it has a thinner central area, which is called the intermediate zone. So the middle of the articular disc here is called intermediate zone. And the articular surface, okay, the articular surface of the condyle functions against the disc's intermediate zone. So the condyle has to be on the intermediate zone of the disc. Okay, that's why it functions. Now, the anterior and posterior portions of the disc are considerably thicker, make sure you keep that in mind, than the central portion. And the posterior portion is normally slightly thicker than the anterior portion. All right. So the anterior posterior portion of the disc are thicker than the central. And however, when you compare the anterior and the posterior part, okay, the posterior part of the disc is thicker than the anterior. And now this makes sense because you want the condyle to go forward, but you never want the condyle to go backward, because if you go backwards more, then you're going to put pressure on the retrodiscal tissue, and that causes pain, because retrodiscal tissue has a lot of vascular supply and also has a lot of sensory tissues. Okay, so you have to, so the disc is also thicker medially and laterally. So it is very thick, anterior, posterior, medial, and lateral, just to make sure that it stays on the condyle. All right. So by design, the middle is the central portion, the intermediate zone is very thin compared to the lateral, medial, anterior, posterior. Okay. All right. So you can see here the condyle has translated, okay, onto the articular eminence, this articular eminence, you have the condyle here, and you have the disc. Okay, nice picture here. You can see. Now, the articular disc is composed of dense fibrous connective tissue. So, you have dense fibrous connective tissue covering the glenoid fossa and also the articular surface of, so the glenoid fossa and the articular surface of the articular eminence are covered by dense fibrous connective tissue. Also, the disc is formed out of dense fibrous connective tissue. Okay. The disc demonstrates flexibility. So it's a flexible disc during translatory movement. It does not appear to be compressible. It is flexible, but it is not compressible. You cannot compress it anymore. Okay. But it is flexible. And the disc is avascular. It has no blood vessels, and it lacks innervation. The disc does not have any nerves. There's no nerves in the disc. Okay? So there's no blood vessels in the disc and there is no nerves in the disc. It is avascular, okay? And it has no lymphatics either. So you have to know that. All right. So the articular disc is attached to the medial and lateral pores. All right. So this is the, let me show here. This is the medial. This is the lateral. Okay. And you would say, other than the words which says MDL, okay, medial ligament, and LDL, that's not lipoprotein, okay, that's LDL, meaning lateral ligament, all right. Now, how do you know this is medial, this is lateral? Now remember, the medial portion of the condyle is pointed, is more pronounced. So if you see here on the medial, you see this point here, that point is pointed compared to this point here, okay, which is blunted. So you know that's the medial portion. The articular disc attaches to the medial and the lateral pores by way of collateral ligaments. Now, what's the other name of collateral ligaments? They are called discal ligaments, okay? And the lateral ligament, the collateral ligament and the discal ligaments, okay? They are responsible. They are responsible for dividing the joint into superior and inferior joint cavities. So what's the purpose of the collateral or discal ligaments? Okay, it is to divide the joint into superior and inferior joint cavities, but also they maintain, okay, they maintain the disc. They maintain the disc on the condyle. Remember, they attach the disc to the condyle, but also they form the superior and the inferior joint cavities. All right. So here you have, so the condyle has two movements. Okay. You have rotation, which is also called hinge. When you say the condyle is hinging, it's the same. The condyle is rotating, it's the same. Okay. So hinge or rotary movement occur in the inferior joint cavity. All right. So when you open for the first 14 to 14 to 25 millimeters. So the first 25 millimeters, all right? So the first 1/3 of opening, which is 25 millimeters, is called rotation. The condyle just rotates, okay, or hinging. It's a hinge, all right. And then when you try to open some more beyond 25, so 25 to 40 or sometimes up to 60, and then you have translate. So the condyle moves against the posterior surface of the articular eminence, all right. So translatory or sliding movement occur in the superior joint cavity. The joint is classified, all right. So what you call the TMJ? The TMJ is also known as a ginglimo-arthroidal joint, all right, and has been described as a hinge joint with a movable socket, okay. So ginglimo, meaning hinge, and arthroidal, of course, arthroidal, no, anything arthro meaning joint, okay, movable joint, okay. So make sure you know, where does the hinge or rotary movement occur? They occur in the inferior joint cavity, and that involves the first 14 to 25 millimeters of opening, and then beyond the 25 to 40 millimeters, then that's you have translatory movement in the superior joint cavity, okay. And what's the other name of the TMJ? The other name is ginglimo-arthroidal joint, all right. Now let's look at the disc, okay. The discal ligaments are composed of collagenous connective tissues, okay? And the collagenous connective tissue fibers do not stretch, and they function to restrict movement of the disc away from the condyle, okay? So the collateral or discal ligaments, they attach the disc onto the condyle. So right here, this ligaments here, okay. So CL is called collateral ligament, okay. This ones here, they attach the disc onto the condyle, but they also prevent the disc from moving in any other direction. Just make sure it doesn't get caught in between damaging structures, okay. Sometimes when you get caught like that, then you can have some displacement of the disc, and then you have clicking, pain, and all those internal derangement of the disc, okay. All right. So the disc ligaments, they also allow the disc to move passively with the condyle. So because the articular disc is attached to the condyle by way of the collateral ligaments, or if you want, the easy name is discal ligament, then when the condyle moves, the articular disc moves, okay. All right. The discal ligaments they also allow the disc to be rotated anteriorly and posteriorly onto the articular surface, okay. And the discal ligaments, they have vascular supply. So the disc does not have any vessels, it doesn't have any nerves. However, the discal ligaments, okay, discal ligaments, or the other name is collateral ligaments, they have blood vessels, they also have nerves. The innervation of the discal ligaments provides information regarding the joint position and movement. So straining on the discal ligaments will produce pain because they have nerves. Okay. So I told you when the discal ligaments become stretched and you start having internal derangements or the TMJ dysfunction. All right. So we just saw the discal ligaments, how they attach the disc to the pores of the conda, to the medial and lateral pores. Now we're going to look at this nice ligament, which is also called temporomandibular ligament or lateral ligament. Okay. So each temporomandibular joint is surrounded and encompassed by capsular ligament. Okay. The capsular ligament attaches superior to the temporal bone in the area of the fossa and eminence. Now, the capsular ligament attaches inferiorly to the neck of the condyle. All right, so make sure you know where the capsular ligament attaches. The capsular ligament resists. What's the function of the capsular ligament? It resists any medial, lateral, or inferior forces that tend to separate or dislocate the articular surfaces. Okay, and this ligament, the capsular ligament, is also responsible for the retention of synovial fluid. That's another function of the capsular ligament. So make sure you know the function of the capsular ligament really well. All right. And the innervation of the capsular ligament provides proprioception feedback concerning the position and movement of the joint. Okay, so remember, all these ligaments, they have nerves except for the other one, except for the disc. The disc doesn't have any blood supply, doesn't have any nerves. Okay, so the anterior portion of the temporomandibular joint has the superior belly of lateral pterygoid muscle. Okay, so the lateral, okay, so the superior belly of, this is the superior belly, superior belly of lateral pterygoid. Okay, muscle, and the inferior belly is going to be attached here, okay, on the neck of the condyle. All right, so now the superior belly of the lateral pterygoid muscle attaches to the, number one, it attaches to the articular capsule. Okay, articular capsule meaning attached to the disc. Also attaches to the anterior border of the disc and the anterior surface of the neck of the condyle. Make sure where the superior head of lateral pterygoid muscle attaches. Now, the majority of fibers of the superior belly of lateral pterygoid muscle, which is about 60 to 70%, attached to the neck of the condyle, and only 30 to 40% attached to the disc and the capsule. All right. So you can see here, you can see the majority of that muscle is just attaching to the neck here instead of attaching to the disc here. Okay. And the inferior belly, now remember the lateral pterygoid muscle has two bellies or two heads, the superior belly and the inferior belly. The inferior belly of the lateral pterygoid muscle attaches to the neck, okay, of the condyle. All right, so you have the bilaminar zone, okay. Bilaminar zone consists of two layers, two strata. So strata is layer. So the bilaminar zone consists of two strata of fibers with loose alveolar connective tissue filling the space between them. And the superior lamina is composed of connective tissue containing many elastic fibers. All right, and these fibers serve to counteract the forward pull of the superior lateral pterygoid muscle. All right, so the lamina, the bilaminar zone is this one. It's called the bilaminar zone because you can see it's laminated here and here. So this area here is called the bilaminar zone and counteracts, okay, meaning prevents the disc from moving too far forward. All right, and the bilaminar zone has elastic tissue, so it stretches. All right, so that when you relax, it pulls the disc back. All right. All right. So the inferior lamina, excuse me, let's see here. So the inferior lamina is composed of mainly of non-elastic collagen fibers. And the inferior lamina serves as a check ligament. Okay, meaning it prevents the condyle from the condyle or the disc from moving too far forward. It serves as a check ligament that passively limits the forward rotation of the disc on the condyle. Okay, that's the function of the bilaminar zone. All right, so the retrodiscal tissue is a highly vascularized and innervated area, okay, right behind the TMJ, okay. So if you can go back, let's see if you can go back here. See a picture here. So here, this retrodiscal tissue is the tissue behind. So this tissue here is called retrodiscal tissue, and it has so much blood supply, so much nerves. Here on this histology here, you can see that this is the condyle, this is the disc here, and the retrodiscal tissue is right here. Okay. So it has a lot of vessels, it has a lot of nerves, and it is a major contributor to the synovial fluid metabolism. So the function, one of the main function of the retrodiscal tissue is to produce, okay, the synovial fluid and metabolism of the synovial fluid. The synovial fluid ensures free metabolic exchange. That's the main function of the main function of the synovial fluid in the TMJ is to ensure the metabolic exchange, okay, such as nutrients, and also provides lubrication of the articular surfaces in both the upper and lower joint cavities. That's the purpose of the synovial fluid. Okay. Here, where you see the arrows here, you can see those arrows are pointing to the retrodiscal tissue, okay, that produce and also metabolizes the synovial fluid. Synovial fluid lubricates the articular surfaces by way of two mechanisms. One mechanism is the boundary lubrication, okay, and the boundary lubrication occurs when the joint is moving, and the synovial fluid is forced from one area to another. So that's the other thing. That's the other problem when the somebody who's not talking too much or not exercising the TMJ, then you start having problems because the lubrication is not being conducted properly. Okay, so when you're talking or you're moving the joint, then you have more lubrication. That's called the boundary lubrication mechanism. Okay, so the synovial fluid located in the border or the recess areas is forced into the articular surfaces when you move your joint. Okay, so it comes, the synovial fluid may be in this area, and when it moves, then it goes onto these areas and also onto these areas. Okay, lubricates the surfaces. All right, and then the second mechanism that the synovial fluid lubricates the TMJ is by whipping lubrication. And the whipping lubrication results from the ability of the articular surface to absorb. So whipping is when you absorb, okay? It absorbs a small amount of synovial fluid, okay? And then the fluid is forced in and out of the articular surface during function. All right. The temporomandibular ligament, okay? So there is, remember, there's a capsular ligament, which we talked about. You have to know the function. Then you have to know the temporomandibular ligaments, okay? Stabilize the disc and condyle complex. And the temporomandibular ligament, they reinforce lateral aspect of the capsular ligament. All right. So now you have to see that the temporomandibular ligament, they have two, okay? There's an oblique part and also you have the horizontal part, okay? They are composed of two parts. Okay? And the function of the temporomandibular ligament is to reinforce the lateral aspect of the capsular ligament. All right. So, what are the two components of the temporomandibular ligament? All right, the temporomandibular ligaments, two portions. Okay, you have the horizontal and you have the oblique, and you have to know them really well. Make sure you know those. So the outer surface, the outer part of the temporomandibular ligament, the temporomandibular ligament, which is also called the lateral ligament, extends from the outer surface of the articular eminence and the zygomatic process to the outer surface of the condylar neck. All right, memorize that definition really well. And the outer oblique portion, okay, the oblique portion limits rotation. It limits rotational opening of the mandible. So when you're opening that's the first hinge movement, which is 14 to 25 millimeters. The reason you stop is because there's now the lateral ligament or temporomandibular ligament is limiting from rotating any further. And then if it can't rotate any further, then it translates. Okay, and that is a function of the oblique portion of the temporomandibular ligament. Make sure you know that really well. Okay, because so the oblique portion of the temporomandibular ligament becomes taut, becomes tight when the teeth are 20 to 25 millimeters apart and contributes to translatory opening of the mandible. So because it becomes too tight, that's when now the condyle goes into translation. And then you have the horizontal portion, of the temporomandibular ligaments, which extends from the articular eminence and zygomatic process, okay, of the lateral part of the condyle, and then attaches into the posterior part of the articular disc. And the function of the horizontal portion is, okay, it limits the posterior movement of the condyle. So the oblique portion limits the rotation or the hinge movement of the condyle. The horizontal portion of the lateral ligament or the temporomandibular ligament limits the posterior movement of the condyle. And so it protects, by doing that, it protects the retrodiscal tissue from trauma caused by the posterior displacement of the condyle. Remember, the condyle, it does not rest in the posterior glenoid fossa. It rests in on the superior anterior, on the posterior surface of the articular eminence. All right. So that position protects the retrodiscal tissue. Remember, the retrodiscal tissue has blood supply, has nerves. So all those things, if you push on it, you can have pain. Okay. So let's look at the ligaments of that contribute to the TMJ. We have already looked at the collateral ligament. We looked at the capsular ligament. We have looked at the temporomandibular ligament, which is consists of two parts. One of them is the oblique, and the oblique part limits the rotational movement, and the horizontal part of the temporomandibular ligament prevents the posterior movement of the condyle, therefore protecting the retrodiscal tissue. And now we're going to talk about the sphenomandibular and stellomandibular ligaments. Okay, so you have to know them also. And the sphenomandibular ligaments, they have been described as accessory ligaments for the TMJ. However, neither ligament has a functional relationship, even though they are called stylomandibular, sphenomandibular. But one of the functions is they limit maximum opening. Okay, so you don't want to open too much. So those ligaments they limit the maximum opening also. And there's a disease which you have a calcification of the stylar process. Remember, stylomandibular ligament attached to the stylar process, and so sometimes when there is a calcification of stylomandibular ligament, you can have some headaches when turning. Okay, you have to keep that in mind. Now, you have to know the attachments of these ligaments. So the sphenomandibular ligament extends from the spine of the sphenoid bone, which is the reason it's called sphenoid bone, and to the mandible. Okay, so it's very easy, from sphenoid to the mandible. Now it goes from the spine of sphenoid. Make sure you remember the spine. Don't just remember sphenoid. Remember the spine of sphenoid, because the sphenoid is huge. It's a huge bone which looks like a butterfly, and attaches to the lingula. Okay, attaches to the lingula of the mandible. Okay. Now, the sphenomandibular ligament has been suggested that the ligament protects the neural and vascular structures entering the mandibular foramen from tensile stresses during mouth opening. Okay, so make sure you remember that. Now let's look at the stylomandibular ligaments. The stylomandibular ligament is this ligament here. Okay, from stylo. Let's see. So this ligament here is sphenomandibular. Okay, and this ligament here is stylomandibular, and you can see it's extending from the stylo process and to the angle of the mandible. Angle. All right. It has been suggested that it limits protrusive movement. Stylomandibular ligament limits the protrusive movement. Okay. All right. So that's the end of it. Make sure you review. It's very high yield material. Make sure you listen to this lecture, listen to it again, and do some of the questions, practice questions, because for sure you're going to be tested on this material. You cannot be a dentist and not know anything about TMJ or just know the surface knowledge. Okay, make sure you know the basics of the occlusion, the effects of occlusion on TMJ, and some of the attachment of the TMJ and the composition of the TMJ. Okay, all right. So the next lecture is going to be the structures related to TMJ. All right.